Dear colleagues, in partnership with the Österreichische Gesellschaft für Nephrologie, the Deutsche Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Dr. David Charytan in Manhattan, New York City, with whom we would like to discuss the role of intradialytic potassium shifts on rates of cardiac arrhythmia in dialysis patients with hyperkalemia, focusing upon his ADAPT study, which has been presented as a late breaker at last year's ASN meeting and published in January in Kidney International, and which we at Marcus at Home selected as one of the most important studies in nephrology in 2024. So dear Dr. Charytan, it's a pleasure to host you.
Thank you. Pleasure to be here, and thanks for the invite.
For a brief introduction, Professor Dr. David M. Charytan is Professor of Medicine and Division Director at NYU Langone Medical Center. Focus of his clinical and scientific work are chronic dialysis, diabetic kidney disease, and cardiovascular disease in the setting of chronic kidney disease. Dr. Charytan is the 2024 recipient of the prestigious J. Michael Lazarus Distinguished Award. So thank you for coming. We're very happy to see your presentation and have the opportunity to ask you some questions.
All right, so just to note, some of this work was funded by Medtronic and other work by an investigator-initiated grant for the ADAPT study from AstraZeneca. So I'll just give a few background slides to set the stage for ADAPT. This is data from the United States Renal Data System. Just to make the point that in brown, the vast majority in this color here of deaths in patients on dialysis is from sudden death, presumed due to a sudden cardiac death and arrhythmia. And that in addition to presumably these fatal arrhythmias, there's, as shown in this slide down here, a very high prevalence of overt atrial fibrillation. In this meta-analysis, estimated to be slightly over 10% of patients on dialysis with overt atrial fibrillation. And when we looked at this in the MID study a number of years ago, I think that was published around 2000. This is the design. I think the actual paper was published a bit later. In the monitoring dialysis study, where we used implantable loop recorders to detect the occurrence of arrhythmias, we found, as shown here, a very high rate, as shown in the bottom box, of occult atrial fibrillation, with 41% of patients in this study showing occult atrial fibrillation, as well as in these boxes quite a high rate of other arrhythmias that might directly lead to sudden death, like VT or severe bradycardia and asystole. And if you just focus on AFib for a minute, we showed in this study a very close relationship to the dialysis cycle. So HD1, 2, and 3 are the actual dialysis sessions each week, and the interdialytic interval broken up into 12-hour time frames in the middle boxes in blue, red, and green for first, second, or third. As you can see in this study, a very high rate of atrial fibrillation occurs, and a marked increase during the dialysis session, and not shown so well here, but during the first couple of hours after each dialysis session. And this was replicated in a meta-analysis where we looked at the body of implantable loop recorder studies. At the time this was published, there were 5 such studies in the dialysis population, but more since. And the take-home point is shown here, is that regardless of whether you looked at new onset AF or recurrent AF, there were quite high rates of atrial fibrillation in the population, either about 20% per year for new onset, or 25% if you include patients with a history of paroxysmal, of loop recorders, so subclinically detected atrial fibrillation in this population, with a high of about 41% in the study we did. So why would we care about atrial fibrillation? Just before we get into ADAPT, is that we know the consequences of overt AF with stroke and cardiomyopathy, and we know the consequences of a severe bradycardia, asystole, or ventricular tachycardia, where you could have cardiac arrest. But I would suggest to you that occult atrial fibrillation, when it's occurring with a high burden, may be a really important event that contributes to the morbidity and mortality of our patient population. So shown here, without getting into the details, just a study in the general population, not dialysis specific, but looking at patients with ICDs or pacemakers, and you can see that the presence of atrial fibrillation detected on these monitors was associated with very high risk of stroke and systemic embolism in this patient population. So cult AF may carry, albeit at a lower risk, the same risk as avert AF for stroke and embolism. It may be an important contributor to the high rate of cognitive impairment in the dialysis population. I won't get into the details here, but all of these MRI findings are very sophisticated indicators of brain dysfunction and anatomic changes or functional changes, and all of these were increased in the presence of occult AF compared to patients without AF. Again, suggesting that this subclinical AF may be an important contributor to cognitive loss in our population, where the rates of subclinical AF are much higher than the general population. And then it may also contribute to cardiomyopathy and heart failure in our patient population. Again, this is a studied people with MI. And if subclinical AF was detected on monitoring while in the hospital, you can see that rates of hospitalization, stroke, and cardiovascular death all went up in the population with subclinical AF at rates sometimes approaching or similar to those with the patients who had overt AF. So I would suggest this is important to you. And then that brings me to the question, why does it happen? And one possibility is, as suggested by the study I showed you earlier, where AF goes up during dialysis. Other arrhythmias also are increased by or occur in sync with the dialytic cycle, although with a slightly different pattern than AF. But one suggestion is that this is overtly due to how we manage potassium on dialysis, with the large shifts in potassium and the creation of hypokalemia post-dialysis, which may predispose to arrhythmia. So this is a very interesting modeling study. Again, without getting too far into the details, these are cell cultures, myocytes. They replicated dialysis by changing the media daily so that the cells were exposed to increasing concentrations of potassium or phosphorus. And then to replicate what happens in dialysis, they rapidly changed the bath to one with low potassium or low phosphorus. And as you can see here, all the EP electrical indicators of dysfunction in these myocytes went up quite dramatically with that rapid decrease in potassium or phosphorus in this model. That replicates what we saw in the monitoring dialysis study, where we found a real interaction, as shown here on the right-hand side, with as potassium and fluid removal went up. So the flux in potassium, the flux in fluid removal went up. There was a dramatically increased rate, as you can see here in the gray box, when potassium went down by 2 milliequivalents per liter. And in patients who had at least 4 liters of fluid removal, we saw a real increase in the rate of arrhythmias, not AF specifically, much less so when the fluid change was small. So again, a clinical suggestion here that the flux during dialysis really matters, although in this case mostly shown for the combination of high potassium and fluid flux. And lastly, just to know what happens on dialysis, which is to say, at least in the US, we tend to check potassium once a month. Assuming if it's high at the beginning of the month, it stays high throughout. But in a study we did, without getting to design, where we checked potassium at each dialysis session in this study, you can see this is the assumption that potassium will be constant throughout the month based on our one-time measurement and the prescription we apply. But this is what actually happens to potassium if you measure it. So that, I'd suggest to you that potassium's all over the map, as you might expect, with varying intake, varying times on dialysis, and so forth. And yet, we put patients on a 2K bath and expect that we're going to avoid hypokalemia. as well as hyperkalemia by doing that. And that's probably a poor assumption. So that brings me now to what I'm here to talk about, to sort of address the issue of whether the rapid flux during dialysis and the post-dialysis hypokalemia might be driving subclinical AF, as well as even more significant arrhythmias like severe bradycardia systole, VTVF. We took a patient population in whom they're on 3 times a week dialysis and had a history of at least mild hyperkalemia, 5 to 6.5 in the preceding period, and had them all get an implantable loop recorder replacement, and then randomized them in a crossover fashion to what we would consider fairly standard dialysis. So that's, at least in the US and in many parts of the world, everyone who's a little bit hyperkalemic getting dialysis throughout the month with a 2K dialysate, or to dialysis with a 3K dialysate bath and sodium zirconium cyclosilicate administered on non-dialysis days only, with the idea of titrating that to maintain the pre-dialysis within what we consider an optimal window of 4 to less than 5.5. There was a roll-in period which didn't contribute to the data, just to accommodate patients in the dialysis period, and then an 8-week period on the treatment that they were randomized to, a washout period, and then patients crossed over to the other treatment with 2 weeks of accommodation and an 8-week treatment period, after which the implantable loop recorder was removed. Our primary endpoint was the incidence of adjudicated AF events, which I've provided, picked up on the implantable loop recorder. I've provided you sort of the background for why we thought that was an important event. It also importantly occurs frequently enough that we might have a chance of picking it up. And secondarily, to look at clinically significant arrhythmia events during the treatment periods only, not during the washout period or the accommodation period, those 2 weeks before. So just the 8 weeks on each treatment after the accommodation period. We also secondarily looked at duration and proportion, a duration of AF over the 8 weeks, or the clinically significant cardiac arrhythmias over the weeks, the proportion of time spent in AF, and the occurrence of potassium values outside of that optimal window. And for safety, we looked at events of hypophosphatemia, hypomagnesemia, hypocalcemia, and other arrhythmia events. This is what the patient population looked like. You can see we had a total of 88 patients, no major differences between the 2 crossover sequences, A and B. And you can see overall, we had about 2/3 of patients less than 65, so a somewhat young patient population, perhaps unique to the, well, not unique to the US, but characteristic of the US and trials in the US. More than half of patients were Black or African American. A few patients had a history of paroxysmal AF, but a low percentage, or other arrhythmia. And most patients had diabetes and had been on dialysis for some time, an average of about 6 years. And potassium values, as expected, were on the high side pre-dialysis at 5.5. That's reflective of the entry criteria. Overall, we had more than 25 years of patient years of follow-up. 9 patients had about 10% had an AF event, with about 300 AF events detected overall. In terms of the treatment period, 123 events were in 6 patients in the 3K with sodium, with SCC, just for the sake of keeping it quick, or Lokelma. So 6 in those participants, a few more events, 173 in 7 participants during the 2K standard dialysis without SCC. In terms of the actual relative risk ratio, so the incident rate ratio, this was highly significant, with a roughly reduction by 50% and an incident ratio of 0.52 with a highly significant p-value despite the small sample size. As summarized here, we reduced events by about half for AF. In terms of duration of AF, the estimate was 1,600 minutes per year less of atrial fibrillation, but that did not achieve significance. And in terms of the proportion of time, also a point estimate of about 0.3% less time in monitoring on events in the right direction, but again, not significant for the secondary endpoint. When we looked at a broader definition of arrhythmias, so clinically significant arrhythmia events, this includes VT and bradycardia. We had fewer of these events, 217 all told. Similar findings, 86 in a slightly higher number of participants, 11 in the treatment group, 131 events, and a few more participants, 13 in the 2K without a binder group, and a similar point estimate in terms of the rate ratio, 0.47. So again, a reduction by about half when using a binder plus 3K compared to standard 2K dialysate. The mean duration was 3 versus 285 minutes per year, and a reduction of about 282 minutes a year. But again, while in the right direction, those estimates didn't achieve significance. In terms of potassium measurements within the window or outside the window, so we have the 2Ks without a binder dialysate in red, and the blue is the 3K plus a binder group. And you can see in either treatment period or crossover group, the number of events outside of that window, either above or below, was much lower in the blue 3K plus binder group. These events were almost all occurring in the post-dialysis measurement, not something we typically do in practice, but was important for understanding what was going on in this study. And when you look at the number of weeks with an event outside of the window, to help you understand this slide, quite a few patients in the 2K group had 6, 7, or 8 weeks with an event, much more of a bell curve with fewer patients having events every week during the treatment period in the 3K. And then just looking at when arrhythmias occurred, again, the blue is the binder plus 3K group, and the red is the standard group. And you can see this is each circle represents a patient with a week during the study and the number of events. And you can see that there were many more events and they occurred throughout the follow-up period. So this patient, for example, had 8 events during this week, compared to this 3K plus binder patient who had 3 events, and so forth, just to help you understand the events occur throughout the time period on either treatment. Lastly, just looking at what happened with potassium measurements, again, the 2K without a binder in red and the treatment group in blue. This is looking at the 3K serum potassium values, and you can see no marked difference with either treatment in the pre-dialysis values. But if you look at the post-dialysis values, I think you can start to appreciate that the blue group has consistently higher post-dialysis potassium values, with fewer outside of the normal range in the treatment group. Looking just at adverse events, hypokalemia was much more common, about tripled in the 2K group, again, mostly post-dialysis. Hypomagnesemia, which is the potential effect of this binder, really didn't occur, nor did hypophosphatemia to any great extent, or changes in calcium. As I mentioned, all hypokalemia events were post-dialysis, no pre-dialysis hypokalemia. And hyperkalemia occurred in 3 patients in the treatment group versus 1. I don't believe any of those events were very severe. In terms of adverse events, one thing of note, very small study, we were not powered to detect significant events. There were more deaths in the treatment group. None of them were felt to be related. And if you look at the adverse events here, slightly higher absolute number in the treatment group. But you can see none of them seem to be, for example, like the respiratory disorders seem to be obviously related to the treatment, although we would need to confirm that in bigger studies. So to conclude, among patients with hyperkalemia on maintenance HD, the treatment with 3K dialysate and a binder on non-hemodialysis stays appeared to reduce in a highly significant way the occurrence of AF, clinically significant cardiac arrhythmias, and hypokalemia compared to routine use of a 2K dialysate without a binder. It was well tolerated with no AEs considered by the investigators to be treatment-related or leading to dose interruptions, and no specific patterns indicating a causal effect. There are important limitations. Small number of patients had events. It's a selected patient population with a relatively short-term outcome period, and needs repetition in a larger hard outcome powered trial. And we hope to look at, but haven't yet been able to analyze, how much of this was due to the dialysate being reduced versus the use of the sodium zirconium cyclosilicate, or whether that's a combined effect of the overall treatment plan. In other words, would just reducing the use of 2K dialysate alone without a binder be sufficient, which is something I'm also looking at. And we need bigger trials. And finally, as an overall conclusion, I would say this contributes to the body of literature that patients on dialysis have a very high incidence of arrhythmia, and even higher incidence of occult arrhythmias that seem to be driven by the dialysis procedure, in particular by high potassium gradients and hypokalemia, particularly after dialysis. And maybe we ought to re-examine our paradigm of trying to avoid hyperkalemia pre-dialysis for trying to avoid post-dialysis hyperkalemia, at least in an equal fashion, if not for prioritization. AF, just as a background, I think may be, even when occult, a very important contributor to morbidity and mortality in this patient population. And we need some long-term trials of smarter and more precise ways of prescribing dialysis.
Well, Dr. Charytan, thank you so much for this presentation. As a cardiologist, we are always worried about hypo and hyperkalemias, and thank you so much for this trial, because it so nicely shows in clinical practice the way that the delta and the gradients really affects atrial arrhythmias in particular. I have a few questions. One was, you showed nicely that also clinically significant non-atrial arrhythmias were different. I mean, the number of patients is low, so maybe it's difficult to say, but what was that exactly? Was it severe ventricular tachycardias? Was it a couple of ectopic beats? What did you see there? I couldn't find that in the manuscript.
No, so it's bradycardias, which off the top of my head, I believe had to last at least 6 seconds.
Okay.
A significant, although not necessarily, potentially fatal bradycardia, asystoles, or sustained VT. I don't think there was any VF to report.
And that leads to the second question. We always wonder, because we do get patients sent by the nephrologists with problems during dialysis. You probably can all teach me there. What's the meaning of something happening during dialysis for the rest of the time the patient is not experiencing these gradients? So is an atrial arrhythmia, atrial fibrillation, which the patient was known with and he is on anticoagulation or not, is that relevant for a day where he is not experiencing dialysis?
So I think when we've monitored our patients, we find that they have both, right? But it's harder to attribute the the arrhythmia that happens on in the morning of dialysis, before dialysis, for example. So, 40 hours after the last treatment, to the hypokalemia that might have occurred, 30, 40 hours earlier. So we do find in the monitoring studies that the rates go up both during dialysis and there's sustained risk or increase in AF burden for certainly 4 to 6 hours, even maybe the 8 hours post dialysis. So it doesn't just happen during dialysis. And I think all of that is probably attributable, at least in large measure, to what happens in dialysis. I think the relevance is probably that, these patients are experiencing that 3 times a week. And I don't know if we know what the burden is for AFib, even occult AF, causing cognitive changes, due to microemboli or hypoperfusion during AF, and, tachyarrhythmia-related cardiomyopathy. I suspect if the patient's on chronic dialysis for weeks or months and experiencing these events all the time for 6 or 8 hours a week, and we do see that in the monitoring studies where some patients have 6 seconds of AF. That you can pick that up on a loop recorder, but that's probably very different than the patients who have 2 hours of AF. Starting with the end of dialysis every session. So, and then I'd say the other way it may be relevant, less in terms of morbidity and mortality, but quality of life, is patients have a ton of post-dialysis fatigue. And I wonder, is some proportion of that because they're in AF and they have, sort of poor cardiac output after dialysis, and not just because we took fluid off. So it may be important that way, although that's really a hypothetical and not is something that's been proven.
But that's very interesting to somebody who's not so into the electrolyte thing. In the nephrology field, and you alluded to that, it's the gradient that's an issue, isn't it? It's not the high potassium. So I wonder, why don't you? Because I know from Gunnar and nephrologist partners who tell me that potassium of 6 in a dialysis patient or even 7 millimoles might not be such a large problem if it's because he sort of gets used to it. Would you agree to that? I mean, the question is, you didn't test the group, obviously, with 3.0 dialysate potassium only and no binder. Just keep the potassium up. Would that be a possibility, or is that?
Yeah, so I didn't. I don't know if you remember the study I showed with the spaghetti plots where potassium's all over the place. That was I didn't have time to go. That was a study where we did in a crossover fashion, but only 4 weeks. A look at feasibility of doing dialysis with sort of a gradient approach, which mostly ended up point of care measurement in it and trying to reduce the gradient. So we measured potassium before each session and tried to reduce the gradient, which meant we were mostly using a 3 potassium versus a 2 potassium. So it's not quite exactly what you said, but very close. And we did that in a pilot fashion. It was too small and we didn't see a major effect, either increase or decrease in arrhythmia. We did not see a lot of hyperkalemia though either. And we believe we have funding to do that in a bigger and better way going forward. Although you may be aware of some dysfunction in the NIH right now. So that's held up starting that study. But I think it's a good question and approach we're interested in. And the ADAPT study doesn't address whether it's the gradient, is it the gradient or the binder, or the fact the binder, or do you need the binder in order to get away with using a lower gradient? We only tested the use of both together in this study, so we can't answer that question.
And particularly since we just had the publication by Dr. Fishbane of his dialysis outcome study, in which the potassium binder actually did not improve the outcome of the patients. So my take after some months, after reading your paper time and again, is really avoid these 2K baths, go for 3 whenever possible. And I'm more reluctant actually to give these oral potassium binders to our dialysis patients who already now have so many medications to take and quite a difficult scheme of medications intake on dialysis days and non-dialysis days. And then finally, one last point from me on this would be that surely there's some sodium burden, at least with this particular potassium binder.
Yeah, we didn't see any events of fluid overload. But again, it's an 8-week study. We only gave it on non-dialysis days. So I don't think that rules out the possibility that in a larger experiment you would see it. And I think ADAPT very much leaves open the possibility that I would say this. Our paradigm has always been hyperkalemia is bad. And I know, when I was a fellow and patients came in with hyperkalemia, we would even sometimes use a 0K dialysate bath. I don't think anybody really does that anymore. And now we're not even using 1K in many places so much.
But you still go for 2Ks for some patients?
Right. We still go for 2Ks. And, I think the question that's raised is, maybe our paradigm has been wrong all along. And, we really do see adaptation to hyperkalemia, and a KF6 in a patient who's used to a KF6 isn't so bad. And what we really need to avoid is either the post-dialysis hypokalemia or rapid shift of potassium. I don't know that I wouldn't say we've proven that. It's it's an 80 patient crossover study without hard outcomes, but I think it raises the possibility that the paradigm needs to be shifted.
The high potassium from a cardiology point of view is 2 issues. The one thing, and I completely agree, I don't think it's such a problem if a dialysis patient has a potassium of 6 or 7, because he's usually fairly stable. I mean, we all are afraid and we all start to shout and run away, but in fact, people are used to that and they're not so. But on the other hand, we have our heart failure therapy, which leads to higher potassium and which is then stopped by the nephrologist, by the cardiologist, by the GP because we're afraid of high potassium. And obviously you cannot show that in an 8-week trial, but the question would also be, did you see any, well, you couldn't see endpoints obviously, but did you see any change in medication of things like spironolactone, which is difficult on dialysis anyway, I know, but or is that sacubitril valsartan or any other heart failure therapy?
No, we didn't, but I don't, it's not data that we've specifically looked at either. So nothing that jumped out to us, but that was not an analysis that's been specifically done yet either. So, and I don't think if we went back, these were hyperkalemic patients, so I'll bet you we didn't have too many patients who were on spironolactone and so forth to begin with, and sacubitril valsartan, mostly isn't used in dialysis patients, so there probably wasn't anyone on that to start out.
And Stephan, even outside of dialysis patients, again, we would have no benefit from potassium binders in your heart failure studies like Diamond, like Realize-K. At least Diamond was set out to show a benefit on heart outcomes. I'm aware it was then stopped before being large enough, but in both studies, actually, you had a tendency towards more events rather than less events. So again, here I'm somewhat reluctant. One more question from my part. So how do you recommend your dialysis patients in the States nowadays with regard to potassium intake with dietary intake? So we had Dr. Clegg here and Dr. Palmer who said that they are much more liberal than in ancient times, where we were really trying to teach our patients to avoid nearly any kind of fruit and vegetables. So what would be your recommendations nowadays?
Yeah, I think that's not exactly addressed by our study, but a good question. I think you're alluding to the fact that over and over again, like the sort of cohort study type of data suggests really no measurable correlation between dietary potassium intake and potassium concentration. So I think it's probably, and especially with the availability of a binder, and maybe you don't need to use it every day. And maybe if we can be more liberal about hyperkalemia, it's probably fairly reasonable to liberalize those recommendations. You may have to fight against the dietitians who, by law in the U.S. meet with the patients on a fairly regular or regulation every so often. But I personally, would scale back on those recommendations. I do think, it's questionable. It doesn't make a lot of sense that what you eat shouldn't correlate. So that's what's puzzling. But I think the data shows over and over again that we can't measure it. So it can't be that big an effect. It's probably mostly just what we do on dialysis is so much more important.
So, Professor Charytan, also from me, thank you for your detailed presentation. As a nephrologist working in the dialysis unit, I know how hard it is to convince dialysis patients to take part in a study, especially one with an implanted loop recorder. So, of course, we always have a question about the transferability to European countries, because I wanted to ask you, how long was your average dialysis duration for the patients in Germany? It's often at least 4 hours, mostly a little bit longer. So how was your dialysis duration and your routine on your dialysis department?
That's a good question. Let me just see if that was listed. I flew through the slides. I would suggest that it's going to be less than 4 hours, because I think that's so it's not. Yeah, I'm gonna have to look that up. That's a very good question. I would suggest to you that it almost certainly is less than 4 hours, and probably in the range of somewhere between 3 and 3.5 hours, because a substantial number of patients get 3, a lot get 3.5, some get 4. More than 4 is uncommon in the U.S. So, but if I know that the DOPS data, for example, shows over and over again that throughout the world, 2K is the most commonly used dialysate bath. I think that's probably true in most of Europe also. So if anything, the effect might be worse of using a 2K on a longer dialysis session. Normally we think of longer dialysis is better, but you're going to continue to remove more potassium and have a greater shift with a 4-hour dialysis session. So this is a little bit different than the effects of fluid removal. It might be worse with a 4-hour than a 3-hour session.
I have another question. So, what's your preferred anticoagulation with dialysis patients and with atrial fibrillation? I know it's a big question, and every expert you ask have another opinion or favors another medications.
Yeah, I think that's a very good question. I think it remains an open question as to whether there's any benefit to anticoagulation at all in the dialysis population, particularly if there's any reason why we think bleeding risk is increased. It certainly hasn't been shown yet in a convincing way in this population, and bleeding seems to be much more common. That said, I think the overall data suggests if you're going to anticoagulate, probably apixaban is better than vitamin K antagonist. But there isn't really clear data, showing benefit. But I think if you look at the 2 randomized studies, both of which were underpowered, there's at least suggestion of some benefit with the apixaban, but we don't have good data. You didn't ask this question, but I would say a really important corollary question is if there's any benefit to anticoagulation is, ought we to be anticoagulating for these subclinical events, and if so, what the burden has to be before we anticoagulate. Off the top of my head, I think there is some data now to suggest some benefit with patients who have at least a real burden of subclinical AF in the general population, where risk of anticoagulation is less than in the dialysis population. But even that data is not very definitive, and I don't think it's really standard practice yet. Maybe our cardiologist can address, but.
Well, thank you so much, Dr. Charytan. I think this really brings it sort of to the point. I mean, I think the whole issue is we're so grateful for these data that the ADAPT study and all your work brings into the field, which really has so many open questions still to answer, and so much more space though than for more studies, and we are hoping to see more of you in the future. Again, as you said, open versus or overt versus concealed or clinically inapparent AF, then the effect of potassium, the clinical effect at the end of the day with you looking at outcomes is so difficult, as you all said, in dialysis patients, which is fortunately not the majority of my patients, because as we know now, the dialysis studies, so many of them were neutral in the end, because people tend to get other events again, apart from what we try and treat. So, well, thank you so much, and thank you also for answering all our questions. I think as so often, we have more things to think about and hope to discuss with you in the future. So, well, thank you.
Thank you. I enjoyed the opportunity to present here.